Assalamu alaikum everyone. Welcome to you all on our today's session. It's about neurodynamics of lower limb, and our guest speaker is Dr. Urul. First of all, I want to give you a short intro of our organization. So our organization name is Physio Health and Fitness, and our motive is to spread the awareness about the physical therapy in health and fitness management. So the founder of our organization is Ma'am Tania here, and I am your host today. Myself, Dr. Rubab Ali. I'm from the UHS, and I'm working in our organization as an ambassador of the University of Health and Science. So today's session is about the neurodynamics of the lower limb, and which our guest speaker is none other than Ma'am Uruj, Dr. Uruj Khan. She did her bachelor from Liaquat National University and master's from the University of Health and Science, and currently she is lecturer physiotherapist at SIPMR. So we warmly welcome Dr. Uruj Khan in our today's session.
Should we start?
Yes, ma'am, we can start.
Okay, thank you so much. Assalamualaikum all, and welcome in this webinar. Today we are going to discuss regarding neurodynamics. Basically, today we are going to discuss about the clinical neurodynamics for the lower limb. But before we proceed towards the neurodynamics of the lower limb, let us discuss about what clinical neurodynamic is. So let me share my screen. Okay, so if we talk about the neurodynamics, so what is a neurodynamic? Let us talk about neurodynamic. Neurodynamic is created or defined by the Michael Shekloff. He is the one who created the neurodynamics. My screen is not sharing. So basically, neurodynamic is you can, as a physiotherapist, you could apply neurodynamics for the diagnosis purpose as well as for the treatment purpose. What a clinical neurodynamic is, as our musculoskeletal system is supplied by the nervous system as well. The nerves conducting neuroconduction velocity, and it is supplied to the muscles, to the area that is controlled by the nervous system. And if somewhere between the nervous system and the muscles that are working, that are moving our muscle, that are moving our joint, there is some disturbance. So then the problem arises. What is the neurodynamic? It is the application of the mechanical and physiological effect of the nervous system to the musculoskeletal system. How the nervous system is coordinated or integrated with the musculoskeletal system. By the it is supplied by the three main way. Like it could be at the mechanical interface, or there is a axonal or central nervous system that supply its pathway, and uh, the and that part, that area that is supplied by the nervous system, basically it is divided into these three portions. I think my presentations are not sharing here. Let me first share my presentation. Okay, so okay, sorry. So let's start. So let's start with the let's start with the starting. What is a clinical neurodynamic? It is essentially clinical application of the mechanics and physiology of the nervous system because they are interrelated with the musculoskeletal. Basically, clinical neurodynamic is created by the Shacklock in 2005, and he's the one who created neurodynamics to apply at clinics and with the clinical application with the ability to assist the the nerves that supply to our musculoskeletal system. We are also able to treat what these clinical neurodynamics. And if we talk about the neurodynamic as a system, so we separated it into three separate categories. Like first one is a mechanical interface. Mechanical interface is the thing in which you are in which those structures which are supplied by the nervous system, for example, skin, tendon, joints, and fascia, all these are counted as a mechanical interface. Mechanical interface are those structures which are just next to the central nervous system. Then the next one is the neural structure. What is the neural structure? Neural structure is in which we counted the central nervous system. In the central nervous system, the brain and the spinal cord is included, and the internal structures like the dura mater, arachnoid matter, pie matter, and all the membranes of the brain and the spinal cord, and nerve roots that are arising from the central nervous system are included in the at the neural structures. Then in the third main category, uh, we included innervated tissues. Innervated tissues are those structures which are supplied by those nerves. In our body, there are many peripheral nerves that supply nerve conduction velocity to the different parts of the body, to the different structures of the body, to the different muscles of the body. So uh, these three separate categories interrelated to each other and supply the nerve conduction velocity. And with the nerve conduction velocity are joints, ligaments, and the nerves work effectively, right? If we have something, if we um, if we divide the function of our nervous system, so it is divided into three categories. Like nerve could be in a tension position, nerve could slide, nerve could compress. These three main functions are of a peripheral nerves. Peripheral nerves could be work in these three categories. Like how you could give tension to the peripheral nerves if you elongate the both ends of the nerve. So the nerve could be in a tensional stage in this way. If we talk about the gliding of the nerve, so in for the gliding of the nerve, only the one end of the nerve will move. Either you could glide from the proximal end, or you could glide from the distal end of the nerve. And then the third one is the compression. Compression is like if nerve is passing beneath the muscle. So yes, it could be compressed when the shape of the muscle will change. So these are the normal function of the nerve. But it is in a certain way. It has some specific limitations. Like if the nerve is in a tensional position beyond the limits, or if the nerve will in a gliding position for prolonged period of time, or in a wrong direction, or if nerve will compress uh, like beyond its limitation. So it will impact the mechanical uh, the mechanical function of the musculoskeletal system, and it will not work according to the scenario, and it will disturb the function of the musculoskeletal system. So, for making our musculoskeletal system work in an effective way, we need to make our uh, neurodynamics in a good and healthy functional state. Uh, how you could make it in a good functional state, like you should keep your posture in a correct way. You should not keep it your posture it at any one specific position for prolonged period of time. You should need to move your body structure, your body parts, uh, in a way that is a correct position, and you should not keep your body position for a prolonged period of time in one specific position. If we keep our body position in one specific position for prolonged period of time, they will definitely affect our nervous system as well as our musculoskeletal system, because whenever your muscle will in a shortening position, uh, with that muscle your nerve is also will be in a shortening position, and if the nerve and muscles both remain in a shortening position for prolonged period of time, they will not function properly when they will be in a shortening position for prolonged period of time. Whenever you are going to flex your elbow, so your posterior aspect is in a stretch position, and your anterior structure is in a flex position in this way. So your anterior compartment muscles in this way will be in a concentric position or in a shortening position, and the posterior compartment muscles will be in eccentric movement. So in this way, one nerve will be in a lengthening position for prolonged period of time, and the another nerve that is present at the front or the anterior half of the arm, it will be in a shortening position for prolonged period of time. So if the nerve will remain in same position for prolonged period of time, so they will not function effectively in this way, or they could be in a improper function. So when we talk about the tension, what is the tension of the nerve, or how the nerve can be in a tensional position? When you elongate the nerve from the both ends, like you elongate the nerve from the proximal as well as from the distal portion as well, so the nerve will be in a tensional position. Like I could show you, like if you want to create median nerve into a tensional position, so I just keep my elbow, my fingers in extension, my wrist in extension, and then I will also lateral flex my neck in an opposite side flexion. So in this way, my nerve is elongating from both sides, from both ends. So if the nerve is lengthening from the both ends, this is known as the tension of the slide. Uh, if we uh, if we talk about the gliding of the nerve, how you could create the gliding of the nerve, or how the nerve glides. If you talk about if I just glide the median nerve, so again I'm going to create extension position at elbow, extension at wrist, and now my neck is at neutral position, right? Whenever I need a gliding at the nerve, so I will only create elongation or lengthening at only one end. So by this way, I am creating elongation at the distal part of the nerve, right? If I want to create lengthening or elongation from the proximal end of the median nerve, what I will do, I will just lateral flex my neck, and then I will remove the distal component. Like I will flex my wrist. I will flex my wrist and I will just lateral flex my neck. So by this way, you could create a sliding of the nerve. How someone could create compression at the nerve. So if the structure from which the nerve is crossing, if that will distort or it's change its shape, so by this way there will be a compression at the peripheral nerve. So by these three ways, you could create a tensional or a sliding or compression at the nerve. Um, at certain aspect or at certain position or at certain uh, length, tension, sliding, compression is acceptable, right? This is a normal function of the nerve. That if the nerve could not in an tensional position, or if a nerve could not in a sliding position, so the nerve conduction velocity could not conduct it, or it will not it will not uh, it will not uh, conducted the information that is necessary for the movement, like so at a certain position, at a certain length, it is required and it is acceptable and it is normal. But beyond that position, like if you will create a tension at your nerve for a prolonged period of time, or if you will create a compression at your nerve for a prolonged period of time, so this will lead the this will lead the nervous system or the nerve to impact the nerve conduction velocity in a negative way, right? So for a certain position it is good, but beyond that it is not good for your body, right? This is sliding, this is compression, and now the neural tensional and neural movement. How you could create a neural tensional and neural sliding, as we already discussed about that if you want to create a tensional movement, so we will move the both ends of the nerve, and this is the viscoelasticity of the nervous system. It is not the nerve is stretching. in which when we are elongating the both ends of the nerve. This is not the nerve stretching. This is a tensional position. And in a slider position, we have already discussed that we only move the proximal or the distal portion of the nerve. In a tensional or a slider, for creating a slider and tensional slider, you could produce a slider position in the mid range. Like, for example, for if you need to create neurodynamics at static nerve, so after 35 degrees, there will be starting nerve gliding. But when you go beyond the 70 degrees, the nerve will be in a tensional position, right? When the both ends of the nerve will get started elongation. So that position will be known as a tensional position. So you could create a nerve sliding in a mid position, and you could create a nerve tension at the end of the range of motion, right? So let us now discuss about the neurodynamics of the lower limb. Okay, so the neurodynamics of the lower limb. There are some nerve that supply the lower limb, which we discuss today. First, we will talk about the peroneal nerve. Where you could find the peroneal nerve, or where you could palpate the peroneal nerve. So you could palpate the peroneal nerve just medial to the bicep femoris muscle, like here. You just lateral aspect, इसके medial आप जो है वो just आप जो है वो peroneal nerve आप इसको palpate कर सकते हैं, or you could palpate it at the head of the fibula, or you could palpate it at the dorsum of the foot. So how you could how you are going to create a neurodynamics, or how you could create a tensional or a gliding at a peroneal nerve, and which common entrapments and syndromes could be seen with the entrapment of the common peroneal nerve. With the entrapment of the common peroneal nerve, you could someone could have lower lumbar spine syndrome, piriformis area syndrome, superior tibiofibular joint syndrome. Lower limb compartments can be entrapments or ankle extensors retinaculum. So how you could assess or release the peroneal nerve. For the peroneal nerve, you just need to do plantar flexion at ankle, then inversion at ankle, and then you will need to do SLR. And if you will keep this movement, and with this, you will keep the neck of the patient or the participant in a flex position. So it will be a tensional of the peroneal nerve. And if you just want to create sliding at the peroneal nerve. So just perform plantar flexion, inversion, and SLR. Okay, so this is the test for the peroneal nerve. You just perform plantar flexion, then inversion, and then SLR. This is the test for the peroneal nerve. Or if you want to create a tensional technique, you just add on neck flexion with this and just stay at the end position. So in this way, your nerve will be in a tensional position. So the next is the self stretch for the peroneal nerve. How you could uh, do a self stretch. How you could do a self stretch of the peroneal nerve. For the self stretch of the peroneal nerve, you just ask your patient to sit in a long sitting and then slightly flex the knee and then perform plantar flexion at ankle and then inversion. And then if you want to create a tensional technique, so just ask the patient to flex the neck and remain in this position. And for the sliding technique, just ask the patient to remove the neck component and just stay in extension position, right? Extension of the neck. There is another way for the self stretch of the peroneal nerve. How you could self stretch the peroneal nerve in another way, like ask the patient to stand and hold the wall, and one leg should be at the back, and you just need to demonstrate that participant or patient just to plantar flex the ankle and invert it, right? By this way, the person could self stretch the peroneal nerve. The second nerve that we usually target is the tibial nerve. How you could target the tibial nerve? For the tibial nerve, you could palpate it at the posterior part of the knee, or you could palpate it at the medial ankle at the plantar nerves, and it could be entrapted in the case with the plantar fasciitis, heel spur, recurrent hamstring injury, or the piriformis area syndrome. It could also affect it in these type of syndromes as well. So how you could release how you could release the tibial nerve. For the release of the tibial nerve or for the assessment of the tibial nerve, you need to perform a dorsiflexion, eversion, and SLR, right? Just you have to lock the knee and then dorsiflex and eversion and then SLR. Again, the same thing for the tensional technique. Just ask the patient to add the cervical flexion component, and for the sliding technique, you just end it with this thing. Then for the self stretch technique, how you could self stretch the tibial nerve. For the self stretch of the tibial nerve, you could do it in a two-way. Like you could perform this in a supine line or as well as in a standing position. In a supine line, you just ask your patient to lie down and bring hip and knee in a 90-90 degree flexion, and then perform dorsiflexion and eversion, and then uh, straightening of the knee. So by this way, the tibial nerve will be self-stretch. और in a standing position में भी आपके पास सेम यही रहेगा. You just ask your patient to perform dorsiflexion, eversion, and then move it in a front direction. So that will be the stretch of the tibial nerve. The next nerve that we will talk about is the sural nerve. For the sural nerve, you could palpate the sural nerve at the lateral to the Achilles tendon, just lateral to the Achilles tendon or distal to the fibula. You could palpate in these two areas. Why we are discussing regarding the palpable areas of the nerve? Because you could also release the nerve of anyone by just applying transverse friction uh, transverse friction massage at these tender points, right? And in which common syndromes and entrapments it could involve. So if there is any recurrent ankle problems, or is there is some Achilles tendinitis in the body of the participants, so it could involve. How you could how you could assess or release it. You just ask the patient, or you just apply the dorsiflexion, inversion, and SLR. Dorsiflexion, inversion, and then SLR. This is, and for the self stretch, it is same like the tibial, but the difference is in this you need to do inversion. like after keeping knee and hip at 90-90 degree flexion, you just ask the patient to perform dorsiflexion, then inversion, and then SLR. And same goes for the sliding or a tensional technique. For tensional technique, ask the patient to add the neck component and remain in that component. And for the sliding, you just need to remove the neck component, or you could also flossing the nerve. How you could do a flossing, like just add one component and remove another component. So this is the flossing of the nerve. So you could perform flossing as well at the nerve. The next nerve that commonly involved is the femoral nerve, where you could palpate the femoral nerve. You could palpate the femoral nerve at the tissue at the inguinal ligament. This is the femoral nerve. It is passing through the inguinal ligament, and how you could assess or release the peroneal nerve. To assess the peroneal nerve, we just check the prone knee bend test and slump knee bend test. This is of your choice. You could do any of the test. So let's first see slump test. For the slump test, you just ask your participant to lie in a sideline position. The one side, which is the tester side, should be at the uppermost side, and the therapist or the person who is checking the nerve should stand behind the patient or the participant, and just flex the knee, um, one hand at the knee, one hand at the pelvis, and you just ask your participant to flex the lowermost leg just to improve the stability. And if you will add the neck component as well, so it will create a more tension at the femoral nerve. Let us see the video for this. Lowermost leg is flex, and the uppermost leg is the tester one. This is the self. This is the test for the femoral nerve, and how you could check in a prone knee bend test. For the prone knee bend test, you could provide a pillow under the knee, and just with that pillow, the hip will be in an extension position, and you need to add the knee flexion and cervical extension. With this, the femoral nerve will be in a stretch position. You could see one more time. Extension at hip, flexion at knee, and you could also add dorsiflexion and add the neck extension component as well. Right, so this is the femoral nerve test, and how you could self stretch the femoral nerve. The prone knee bend test is the same thing that could be a self stretch for the person for the femoral nerve. How he or she could perform the self stretch, just extension at hip, flexion at knee, dorsiflexion, and you could add or remove the neck component, right? If you will remove the neck component, or if you will add on the neck component, so for the femoral nerve will be in a more tensional position when you will add the neck extension, right? Because the femoral nerve is at the anterior thigh. So whenever you will add the neck component in an extension direction, it will create more tension at femoral nerve, right? So this is the tensional position for the femoral nerve self stretch, and this is the sliding position for the femoral nerve self stretch. You could see this video as well. All components are added here. And for the tensional technique, you just need to stay in that specific position for approx 7 seconds or 10 seconds. And if you are performing sliding position, so just add one component or एक component, like आपने neck का add किया, आपने knee का remove कर दिया, knee का add किया, आपने neck का remove कर दिया. You could also perform sliding position like this, जिसको हम nerve flossing भी कहते हैं, ठीक है, जिसमें हम एक साइड का कंपोनेंट ऐड कर रहे होते हैं और दूसरी साइड का हम कंपोनेंट जो है वो ऑफ कर रहे होते हैं. सो दिस इज ऑन एंड ऑफ फिनोमेना इज द नर्व फ्लॉसिंग टेक्निक. Then we will talk about the sciatic nerve. Sciatic nerve is present in the buttock area, and if you need to palpate it, you could palpate it at the posterior aspect of the greater trochanter. जो आपका greater trochanter उसके posterior aspect या फिर lateral aspect of the ischial tuberosity पे आप जो है sciatic nerve को easily palpate कर सकते हैं. How you could assess the sciatic nerve? For the assessment of the sciatic nerve, just keep the leg beyond 45 degree of SLR, and then add the dorsiflexion component, and then add the adduction component and medial rotation at hip. And if you want to create more tension for the sciatic nerve, you just need to add the neck flexion component. You could see in this video. This is on and off phenomena. Just a second. This is the test position in which I perform SLR, and then I add dorsiflexion and inversion and adduction. And for making it more complex, I just add the neck component as well. And if we stay in that end position, so it will be a tensional position. SLR, dorsiflexion, adduction, medial rotation, and then neck flexion. This is the self-stretch for the sciatic nerve, in which he just add SLR and hold the posterior thigh and add the extension at knee, at the dorsiflexion at ankle, and straight the knee component. And if you need to keep it in a tensional position, so you could add the neck flexion component in this. Like this. So the next nerve is the lateral cutaneous nerve of the thigh, where you could palpate the lateral cutaneous nerve of thigh. Lateral cutaneous is also present at the thigh area, just lateral to the femoral nerve. You could palpate it just medial to the ASIS. Anterior superior iliac spine के just आप medial और inferior side पर आएंगे, so you could palpate the lateral cutaneous nerve of the thigh, and the problem that could arise with the involvement of the lateral cutaneous nerve of the thigh is Madal Geoparasthesia. It is commonly found at the in males, those who keep their wallets constantly at one side. So this is the Madal Geoparasthesia condition, in which the lateral aspect of the thigh will be senseless. There will be no sensation at the lateral aspect of the thigh. So how you could assist or release the lateral cutaneous nerve of the thigh? For the lateral cutaneous nerve of the thigh, the position will be the same. Ask the patient to remain in a sideline position, and the tested limb will be the uppermost, and ask the participant to hold the lowermost leg. We will, for the lateral cutaneous nerve of the thigh, we will extend the hip and then uh, apply adduction at hip. See, extension and then adduction at hip. For the lateral cutaneous nerve of the thigh, this is same as the femoral nerve. The only difference in this is we add the adduction at the hip with the extension of the hip. Obturator nerve, how you could release the obturator nerve. Obturator nerve present at the medial side of the thigh. So palpating the obturator nerve is very difficult because it is deep. It is present beneath the muscles, so it is not easily palpable. So we do not palpate the obturator nerve. How you could check or how you could release the obturator nerve? For the obturator nerve, what we will do, we will add the extension at hip, and then we will add abduction at hip, and this is the position for the obturator nerve is the same: sideline we ask the participant to flex the lowermost leg, and to add more component, we add the flexion at the cervical area. So this is for the obturator now. See, this is the obturator now, and that's it. Thank you. And if you have any questions, you could ask me. If you have any question, you could ask.
Thank you so much, ma'am, for your time, and thank you so much all for joining us. If you have any question, you can ask. Ma'am is here to answer you, and you have only few minutes to ask any question. Otherwise, we will end this session.
Yes, if you have any question, so you could ask in a chat.
ओके, इट सीम्स कि किसी को कोई क्वेश्चन नहीं है, सबको लोअर लिम्ब की न्यूरोडायनेमिक्स समझ में आ गई है. सो थैंक यू सो मच मैम फॉर योर टाइम, एंड थैंक यू सो मच ऑल.
My problem.
हम अब ये सेशन एंड करते हैं. थैंक यू
Okay,
मैम.
thank you so much.